Hello and welcome to Medical Dialogues. I am Dr. Nandita Mohan, and today's topic is Metoprolol's contribution to cardiology, a thought leader's chronicles. Now, in this month, we celebrate the World Heart Day, and last month, in August 2024, we celebrated the 46th anniversary of Metoprolol approval. Now, to give you a small brief about metoprolol, it has remained a resourceful pharmacological agent in the cardiology practice in India, and it has stood the test of scientific excellence with robust real-world experience and remains a valuable life-saving agent. Now, to give us his thoughts in detail, we have with us today Dr. Dilip Kumar, who is the director at Cardiac Cath Lab, senior consultant, interventional cardiologist, and electrophysiologist, and a chief academic coordinator at Medica Institute of Cardiac Sciences. As a thought leader in cardiology practice in India, we would like to revisit the journey and reiterate the application of metoprolol succinate in cardiology through his robust clinical experience. So we welcome you to Medical Dialogue, sir. It's really a privilege to be interviewing you here today.
Thank you, Nandita. Thanks for having me here.
Great. Now, sir, if I may ask you, what are your thoughts on the robust legacy of metoprolol in cardiology?
So, thank you, Nandita. And when you look back at the journey of metoprolol, so the beta blockers came in picture when Dr. Blake, developed propranolol in 1960s, and in 1970s, metoprolol came, and since then, metoprolol is enjoying the number one status in India. As far as the beta blockers are concerned, and so beta blockers are unique in many sense, and because once we were undergraduate students, it was a dictum that those patients who were in heart failure, beta blockers were contraindicated in 1990s, and then came the Merit HF trial and some other trials with other beta blockers, and beta blockers were finally convinced, and it got established in heart failure therapy, and this is the backbone of heart failure therapy, in the spectrum of HFrEF patients. And being more cardioselective with lesser side effects of, extra cardiac side effects with metoprolol, it's being the number one beta blockers at this moment, and more so the patients who are having COPD, more patients who are bronchial asthma. There also we can use this beta blocker more conveniently, and patients who have a CKD, chronic kidney disease, again metoprolol has got edge over other beta blockers. So it's indeed such a gratifying thing to look back at the journey of metoprolol, since we are following this entire journey of beta blockers right from beginning, from undergraduate days, from contraindication to indication, and not only in heart failure. Beta blockers are also the number one kind of drugs for hypertension in Indian context. Why I'm saying so? Because in India we see majority of hypertensive patients are younger patients. So our around 40 to 50% of hypertensive population is within 50 years of age. And here the sympathetic surge and sympathetic activity, emotional liability, these play a very important role in hypertension in Indians, and there comes the role of beta blockers, and beta blockers fit very well in our setup in young hypertensives in India, and so in hypertension also metoprolol especially is the most preferred drug, especially in younger population.
Okay, great, sir. So now, which are the indications that you would like to consider for metoprolol in cardiology?
Yeah. So as I told a little while back, heart failure is the number one indication, and hypertension is the second indication, and third and very important class of indication is ischemic heart disease and inguinal patients. So those patients who are having angina on walking and is known ischemic heart disease, beta blockers are life savers because they reduce the burden of and the pain and angina. At the same time, they protect the patient from malignant arrhythmias. So ischemic heart disease patients, as we all can understand, ischemia can lead to arrhythmia, and beta blockers give huge protection from arrhythmias, be it atrial fibrillation, which is ventricular tachycardia, ischemia-induced arrhythmias is really controlled by beta blockers. So these are three cardinal indications for beta blockers in our population and globally as well. And there are some kind of situations where we can give beta blockers, but these are the main three indications: heart failure, hypertension, and angina patients, ischemic heart disease patients.
Okay, great. Now, sir, as per a recently published 2024 expert opinion from Indian cardiologists, that as you also mentioned, beta blockers, among the beta blockers, metoprolol is the first line of treatment for even post PCI and in heart failure patients, as you mentioned. Now, if I may ask, what makes it such a special beta blocker in India?
So number one is the experience and the use and the kind of confidence and faith of using this drug for last 2 decades. So this vast experience makes us more comfortable as number one beta blockers. Metoprolol is being used right from earlier 2000s, and more importantly, it has got huge flexibility in dosing patterns. So we can start from 12.5 milligram, we can escalate to 25, then 50, then 75, 100. So there is a huge range of doses which are available to us, which can which gets handy in titrating beta blockers, because the rule with beta blocker is start low and go slow, and this best suits with metoprolol regimes. And also beta blocker is a selective beta blocker. There is very less extra cardiac side effects. Third is 24-hour sustained action of these beta blockers with very kind of more or less predictable pharmacokinetics. And this 24-hour function of beta blockers, more consistent function, they have been found to be very useful in heart failure with a lot of trials, metoprolol succeeds. So these are the reasons why metoprolol is still enjoying basically the number one position in India. And the final word about the why it is enjoying so much of popularity and use is because in young patients in India, young hypertensives make majority of hypertensive patients, and that is the reason why we use more and more beta blockers in our hypertensive patients, and metoprolol being 24-hour long half-life and 24-hour predictable action becomes a choice by default.
Yes, definitely, sir. And now, if I talk about Indian, now that we're discussing about Indian studies, there's another Indian study which was published earlier, which highlighted that metoprolol as the preferred beta blocker for hypertension management as well. You also, a few minutes back, you just mentioned that was one of the indications why we give metoprolol. So, if you want to highlight anything on it, what is your take on it, sir?
Yeah, so beta blockers in hypertension started with atenolol. So atenolol was once hugely prescribed beta blockers for hypertensive patients, and gradually we came to know that it decreases the peripheral blood pressure, but on the same side it can reversely increase the central aortic pressure. And then the selective beta blockers came, and metoprolol rightly took the place of atenolol. So once again, I will reiterate this fact that this is the kind of we are used to write metoprolol because of its more and more experience and evidence which we have, and its long-acting formulation and predictable pharmacokinetics makes it again a drug which we look for in all hypertensive patients, especially the younger ones.
Great. Sir, lastly, if I may ask, any special metoprolol anecdote from your vast clinical practice journey that comes to your mind, and something that you may like to share with the medical fraternity friends as well?
Yeah, so I tell you, one important use of beta blockers, especially metoprolol, is also in arrhythmia patients, and we seldom ignore patients of arrhythmia, and we send straight away to we see a lot of referrals to us electrophysiologists directly from physicians. They don't try out the beta blockers, use of beta blockers. So I tell you one very a case. He was an orthopedician, and I had implanted an AICD to him, and this AICD was a very advanced machine where we could get blue sync technology with it. So the patient's device was synced with his mobile app, and the data was transmitted to us. So once we put an AICD, he went home, which is 100 kilometers away from Kolkata. And the next 3-4 days, we got transmission from the device. This is called remote transmission. That he is getting, ventricular tachycardia episodes. And we asked him to come again and check with us regarding the device, the programmability, and the reason to look at. But he was adamant because he was having non-sustained episodes, so he was not symptomatic, so he was at home only. So what we did was we escalated the dose of beta blocker, which was given to him, Metoprolol, from 12.5 to straight to 50 as his blood pressure was normal, and the patient was on backup with AICD. Again, the NSVT episodes came down. The patient was also on amiodarone, and then we escalated it to 100 and 150, and finally at 150 we saw that these arrhythmia episodes have really gone to zero, and then that was so gratifying that once it was remotely we treated him. He was having such a malignant arrhythmias, but sitting in Kolkata, managing one orthopedic doctor who is having ventricular tachycardia on AICD with gradually increasing dose of metoprolol, it was a real gratifying experience. And I still share this story with most of the young cardiologists, how far we have come in advancing technology and wonderful drugs which we have in our disposal. And previously, a decade back, these patients were really unfortunate, so we could not know whether he was having NSVT, and we had no ability to escalate the drug right sitting from far place. So this was a very gratifying story.
Great. Thank you so much, Dr. Dilip, for joining us today at Medical Dialogues. It was lovely to be gaining all your insights and all your experience. So thank you so much, and have a great evening.
Thank you, Nandita. Thank you.
Never miss a medical update from Medical Dialogues. Like, subscribe, and press the bell icon.